Well, also from my side, I am thrilled that we can resume the webinar series after our summer break. And thank you so much for joining. Again, this webinar series would not be possible without our sponsors. They are of very great help. For most, of course, Pharma-Mar, and we are very grateful for that. I am thrilled to introduce, I don't need to introduce Javier Martin-Broto. He composed a really thrilling program, not only the topic, but also the speakers. And please feel free to ask your questions through the system. So in the end, we can all answer them and hopefully define new ways. Javier, please take on.
Thank you. Thank you, Bruno. Thank you very much. Hi, everyone. It's my big pleasure to share this webinar on behalf of the Swiss Sarcoma Network. We initiate, as Bruno said, the new season of webinars in sarcoma, organized by Swiss Sarcoma Group with the coordination of Bruno Faust, Axel Sessen, Alexander Gronki, and Janip Splay. We will present the 3 talks in a row, and we preserve the questions at the end, but you can write down questions in the chat in the meanwhile. The headline of this webinar is New Attractive Molecules in Sarcoma Care, and we are very lucky to have 2 relevant speakers, Professor William Tapp and Professor Gerard Brien. I'm very happy to introduce you our first speaker, Professor William Tapp, who is leading the sarcoma oncology team in Memorial Sloan Kettering Cancer Center in New York. He has conducted many clinical research in sarcoma, including trials on MDM2 and CDK4 inhibitors. He will be in charge of the topic, targeted therapy in dedifferentiated liposarcoma. What can we expect from the latest generation of MDM2 and CDK4 inhibitors? So Bill, thank you very much for your contribution in this webinar.
So thank you, Javier, and the organizers for inviting me to talk today. And I'm actually really excited to talk about this topic because it's been something dear to my heart. And I thought I would take a little bit of a different approach to talk about where the research has been going with the last generation of drugs, and then where that will bring us into the future. So I appreciate it. I know this organization, this group does not need an introduction into dedifferentiated liposarcoma, but a rare adipocytic malignancy where we often have the well-differentiated, more indolent form next to an aggressive dedifferentiated form. We struggle, I think, as to how these tumors develop. Many feel that it is an aberration of mesenchymal stem cell development, and if cells arrest closer to an adipose site, they retain PPAR gamma signaling, CEBP alpha signaling, and look like a well-differentiated liposarcoma. Maybe closer to a mesenchymal stem cell, they lose those features, and we see these really aggressive spindle cell malignancies. What we know about these diseases is they have very complex genomes, mostly copy number alterations. Specifically, they almost all have alterations along the long arm of chromosome 12 with 2 amplicons, one centered at CDK4 and one centered at MDM2. And this has really allowed us to consider the contributions that these genes may have had to the pathogenesis and propagation of the disease. We know these amplicons exist in well-differentiated tumors, and as tumors move into the dedifferentiated form, they have an increase in the copy number alterations, again, showing their importance. Just briefly, though, what role could they play in the disease? Well, we know that CDK4 can actually phosphorylate RB. By phosphorylating RB, it can actually remove its protective effect against cells entering into the cell cycle, moving from M to G1 into S phase. So the thought is, by applying selective CDK4 inhibitors, we may be able to inhibit CDK4 and preventing these cells with actually the somewhat broken genomes to dividing and growing. Our group has had a lot of interest in these drugs. Specifically, many years ago, we started to work with palbociclib, which was a CDK4/6 inhibitor now approved in breast cancer. Mark Dixon from our group looked at 2 different schedules. These are drugs that we need to take a break in because of some of the cytopenias that develop. And what was interesting, looking at these two small phase 2 trials in aggregate of about 90 patients, median progression-free survival on both of the trials was about 18 weeks. Response rates by RECIST were very low, maybe just about 4 to 5%. But 18 weeks was fairly reasonable as an efficacy outcome in patients with progressive disease, just getting a single CDK4/6 inhibitor. And for us to put that into perspective, when we think about some of the activity of the drugs that we did study on more prospective trials, it was reasonable. This is just the example of trabectedin versus dacarbazine in the L sarcomas. And if we look at the dedifferentiated subgroup, median progression-free survival for dacarbazine was about 2 months, and the same was true for trabectedin. Both of these drugs are widely used for dedifferentiated sarcoma in both the US and abroad. So seeing some reasonable activity was encouraging. We've also looked at abemaciclib. Abemaciclib is a similar drug, CDK4/6 inhibitor, slightly different off-target effects. This is a drug that can be given continuously because we don't see necessarily the cytopenias. And in a small, again, phase 2 trial of about 30 patients, median progression-free survival was 30 weeks. So again, looking at PFS of about 4 to 6 months in heavily pretreated and patients with progressive disease going onto the trial. Incidentally, the abemaciclib data was encouraging and has led to a randomized phase 3 study. This is now SARC-41, which is a trial of abemaciclib versus placebo in patients with dedifferentiated liposarcoma. Patients with progressive disease can be randomized in a 1-to-1 fashion to receive abemaciclib versus placebo. There'll be a crossover at progression. Target goal is 108 patients, and a successful trial would have a median PFS for abemaciclib of about 23 weeks. So hopefully a trial like this will be able to show efficacy, help us better understand application of the disease, and maybe be able to get the drug approved for usage. But for me, what's important with these trials is really understanding the penetrance of CDK4 and MDM2 in liposarcomas, and are there ways to better understand the application of drugs so we can inform the next generation of inhibitors. What I did for the purpose of this talk is put together a modified swim plot of all the patients who were on the palbociclib study. So again, about 90 patients. And what you can see here is that about a third of the patients rapidly progress through treatment. About a third of the patients in this red circle actually do reasonably well with median PFS of about 4 to 6 months. But then about a third of the patients actually have long-standing stable disease on drugs, some in excess of years. So one of the questions we had early on when we started working with this drug is, why were we seeing this differential response? Why are some patients rapidly progressing through therapy, and why are others actually finding significant stability with drug? And can this inform patient selection, and can this inform how we use the drug moving forward? So about 10 years ago, we started to work with Andrew Koff. Andrew Koff is a world-renowned cell cycle biologist at the Sloan Kettering Institute in New York, who actually helped discover P27 way back when. And we formed a working group with Mark Dixon, who did a lot of the studies, and Sam Singer and Amy Crago, 2 surgical oncologists here. And we wanted to understand what were the effects of this drug on the cell cycle in tumors, as well as what was actually causing the clinical outcomes that we were seeing. Importantly, at the time that this research started, there was a thought that if there was any treatment-induced cell cycle exit, cells could either choose to go into one or two fates. One would be a reversible form of cell cycle exit called quiescence, where cells could toggle back and forth into the cell cycle. The other was a more irreversible form of cell cycle exit known as senescence. And we believe senescence was more of the desirable clinical outcome. With a lot of different lab research that came on, what was shown is that almost any drug, a CDK4 inhibitor or cytotoxic that actually could cause cell cycle exit, the cells will leave the cell cycle and enter into that reversible form called quiescence. but there was a population of cells that would undergo a process of geroconversion, moving from quiescence to senescence. So having the possibility of this pathway really allowed us to begin to dissect out the biochemical events of the pathway to see if we could better understand what was going on in our patients. And it turns out what is critical in the activity of CDK4 inhibitors along this geroconversion pathway is actually the downregulation of MDM2. So CDK4 inhibitors, when they cause senescence, need to downregulate MDM2, another gene that is really instrumental in dedifferentiated liposarcoma. You have dissociation of HAUSP, which is a deubiquitin protein, and then MDM2 can get earmarked for ubiquitination and downregulated. We were actually able to show this in patient samples from our study, where patients who rapidly progressed on study, you could actually see the dephosphorylation of RB, but yet MDM2 was not downregulated. It was only in those patients that had prolonged survival events that we could actually see the downregulation of MDM2. So this was a critical post-treatment biomarker, but also ideas into the efficacy of what was happening with drug. The other thing that was noticed just briefly is there were two genes which were also critical to this process. One was PD-LIM7 that could inhibit the ubiquitination of MDM2, but PD-LIM7 could actually be bound by a cadherin, E-cadherin 18, and if that sequesters PD-LIM7, then actually you would see the downregulation of MDM2. And this is just a proximity ligation assay looking at that. But importantly, what we were able to show is that if you looked at immunohistochemical staining for CDH18 in liposarcoma samples, now these could be historical even earlier on from the treatment of patients, that having IHC positivity for CDH18 was actually a prognostic signature when it came to progression-free survival and a predictive signature. And potentially a predictive signature for overall survival as well on the drug, although with overall survival it could also be prognostic. So why is this important? Because it may be that CDH18 could be a pre-treatment biomarker that could help us identify which patients potentially could respond to CDK4 inhibitors with liposarcoma. So something that we're looking into right now. So not to belabor the pathway, but I think there are some important aspects of this that were also noticed. One is that there's a critical gene called ATRX, which is important for the downregulation of MDM2. This is important because certain liposarcomas have mutations in the C terminus of ATRX. And when we see that mutation, we do not see the cells undergo this process of geroconversion. So ATRS can really affect the gene expression and is required for the loss of MDM2 and CDK4 induced senescence. Importantly, ATRX, which is a SWI/SNF family of chromatin remodeling protein, gets recruited into nuclear foci that actually stabilize senescence-associated heterochromatic foci. And this is important because this is something we can look at in confocal microscopes, and it's predictable and tractable. So it can be used for drug screens to see which cells may be able to undergo geroconversion. And the other thing, because it's predictable, we can actually align cells prior to entering into the geroconversion pathway and then release them and actually sample them at various time points throughout this process so we can mechanistically tease out what is going on. And in doing so, in performing some experiments like ChIP-seq, we were looking for other genes that seem to be involved in ATRX signaling and the downregulation of MDM2. And one of them is HRAS. And HRAS can inhibit the process. And one of the roles of ATRX is actually to inhibit HRAS. And so if we see overexpression of HRAS in certain liposarcomas, we know those are also not the cells that will undergo geroconversion and move into senescence. So why is all of this important? Because it's, for us, creating ways to think about the next iteration of clinical trials. And one of the trials that we're very interested in is another small proof of principle study where we will be combining CDK4/6 inhibitors with specific RAS inhibitors. And we've shown in preclinical models that when we do this, we can not only improve outcomes, but we can also expand the number of cellular samples and mouse models that can actually respond to CDK4 inhibitors. So importantly for us, this trial, which is small, will be rich in correlatives with biopsies pre-treatment, immediately post-treatment, and then in those patients with stability after 6 months, to see if we can better understand this process of geroconversion, the senescence, and the role that MDM2, ATRX, and genes like HRAS play. So we're very excited. This protocol is being written and will hopefully be up and running within the next 6 months or so. The other thing which is really exciting and important is what happens when actually cells undergo senescence. When cells senesce, they secrete what's known, or they activate what's known as a senescence-associated secretory paradigm. And this is a paradigm that plays a lot of role in the tissue. It has implications in aging, but in the tumor microenvironment, it also allows for immunity, mostly to affect the senescent cell. But there's some thought that this immunity could either have a pro-tumor or anti-tumor effect. So there's a lot of interest in seeing if we can manipulate the immunity driven by senescence to actually improve some of the outcomes that we're seeing with checkpoint inhibitors in sarcomas. And we all know now that we can see some very nice results from checkpoint inhibitors in sarcomas. This is just a trial we ran of bempegalduslucan, which is a pegylated IL-2 in patients with sarcoma in combination with nivolumab. And there was a series of patients with liposarcoma. Response rates were low, but what you can see is some of the patients had pretty dramatic progression-free survival rates, some within the course of a year. So Sandra D'Angelo at our group, who ran that trial that I just mentioned, recently got an R01 grant from our NIH looking at immune environment in liposarcoma, specifically in those cells that undergo senescence with a CDK4 inhibitor, and how we can augment that with immunotherapy. And this has led to a clinical trial looking at palbociclib and a PD-1 inhibitor. This trial, also like the one with the RAS inhibitor, is going to be rich in correlatives, so we can study the immune microenvironment and see how senescence may actually affect that. So hopefully getting more aggregate data from the correlative research that will build our knowledge base on how to apply these therapies in select patients. So things that we're looking about is the actions of these drugs. Is it a durable quiescence that allows for the clinical effect, or is it the geroconversion to senescence? How does senescence interact with inflammatory cells? How can we augment that reaction? And potentially, what are the also senescence independent inflammatory aspects of CDK4 inhibitors that we can also manipulate clinically to help our patients? But interestingly, as I mentioned, one of the mechanisms of action of CDK4 inhibitors is the downregulation of MDM2. So there's a lot of interest of the use of MDM2 inhibitors in liposarcoma as well. I personally feel this is a stronger target in this disease. Unfortunately, it's been a harder class of drugs to realize clinically, most because of the on-treatment effect of thrombocytopenia. Mrinal Goundert, our group, has spent a lot of time working with milidatamine, which was an old Daiichi drug, working on the dose and schedule to allow for clinical efficacy in spite of the thrombocytopenia. And it took many years to figure out the right dose and schedule, but when they did, in an extension cohort, we actually saw encouraging results looking at effects in dedifferentiated liposarcoma, a fairly significant disease control rate, and actually slightly higher response rates than we saw with CDK4 inhibitors. This drug was then purchased by Rain Pharmaceuticals, and because of these data, a recent phase 2/3 study was just performed looking at milademetan versus trabectedin in patients with progressive dedifferentiated liposarcoma. So I think this study has finished accruing, and hopefully we'll begin to see the readout to actually see the efficacy pattern of MDM2 inhibitors in sarcoma, which again, I think may be a slightly stronger drug than CDK4 inhibitors. I just want to point out that there's been some interest in co-targeting MDM2 and CDK4 inhibitors, and there was one study looking at this combination again in patients with dedifferentiated sarcoma. When we look at the median progression-free survival in the different cohorts, it doesn't seem to be better than either single agent alone, right? So potentially no additive effect or synergistic effect. And if we begin to think of this zero conversion model that we're talking about, where CDK4 inhibitors actually downregulate MDM2 in a p53 independent fashion, it questions as to whether or not adding an MDM2 inhibitor when the potential MDM2 target is downregulated would allow for specific efficacy. So potential proof of principle of the models that are being developed to understand the biology and potential application in future clinical trials. So just to end, I think we're seeing promising data with CDK4/6 inhibitors and MDM2 inhibitors in dedifferentiated liposarcoma. I think studying these drugs has given us significant insights into their mechanisms of action, not only in liposarcoma, but more applicable to in other malignancies, giving us insight into treatment-induced cellular arrest, the process of geroconversion and senescence, how this is leading to biomarkers that could potentially allow us to select patients for treatment, and also potential combinations, potentially with MAP kinase inhibitors, RAS inhibitors, and immunotherapy inhibitors. And it's also led to the next generation of phase 2-3 studies that hopefully will allow us to move these inhibitors more generally into the clinics for our patients. And all of this, I think, is going to inform the next generation of inhibitors and combinations in sarcoma and other diseases. So I'll end there, and I'll thank you for allowing me to talk about this topic, which has been near and dear to my heart for the past 10 years, and hopefully advancing some science and treatments for our patients.
Thank you very much, Bill. Terrific review in the latest options of inhibiting MDM2 and CDK4 in the differentiated liposarcoma is really exciting. So the questions will be in the end of the meeting after the presentation. So thank you very much, Bill. And I'm very happy to introduce our second speaker, Professor Gerard from Trinity College in Dublin. He has been involved in investigations on BRD9 as a targeted therapy in synovial sarcoma in Dana-Farber Cancer Institute in Boston. Now he's in Dublin, but before he worked in Boston. He will be in charge of the topic, will we have finally a targeted therapy in synovial sarcoma? Thank you very much, Brian.
Thank you. Just let me go full screen here. So I'll just start by thanking the organizers for the invitation to give a talk today. It's great to get to contribute to the group. This is a very long time ago now, but I actually lived in Switzerland for about 6 months when I was an undergraduate. Too long ago now to bear thinking about, but I haven't managed to visit since I lived there, but I should make more effort to come back because it is a beautiful country. So like Javier said, my research is focused on synovial sarcoma, and I'm going to talk over the course of the next 15 minutes or so about some of the work that we've done identifying BRD9 as a therapeutic target in this disease and developing new drugs to target BRD9 function. And I'm aware this is a very kind of clinically orientated group, and I'll just, start by saying that I myself am not a clinician. So my talk is going to be quite different from Bill's just now. So the work in my group is really focused around understanding the kind of core molecular mechanisms underlying disease biology. We do that in a few different contexts, but different pediatric sarcomas, including synovial sarcoma, are some of our favorite contexts to do this work in. So I'm just going to start off by just, for hopefully everybody's benefit, so everybody can follow me as I go through the talk, introduce the kind of research area that we're interested in. So the research in the group is primarily interested in understanding fundamental mechanisms of transcriptional or chromatin biology. So these are some of the mechanisms that control effectively the on-off states of our genes. So obviously, we have about 20,000 genes encoded in our genomes, but not all of these genes are expressed in any given cell type. So we need to have mechanisms that control whether a gene is either on and expressed or transcriptionally repressed. And I'm particularly interested in understanding how chromatin biology, or what people might have heard previously referred to as epigenetics, actually kind of interacts with this idea of controlling transcriptional activation and repression. So I'll just start off with some basic descriptions just so everybody can follow. So what do I mean when I say chromatin? So, in essence, what is chromatin? So chromatin is actually the macromolecular complex in which our DNA exists in cells. So our DNA, as eukaryotes, doesn't exist as a naked strand in the nucleus, but instead it's actually wrapped around proteins termed histones to form this basic repeating subunit of chromatin known as the nucleosome. And nucleosomes are further packaged into a higher order structure known as chromatin. And then chromatin forms what we would know as chromosomes. And as it relates to transcriptional biology and controlling the on and off states of our genes, it's important to know that the packaging of DNA in this chromatin structure in the nucleus isn't uniform. So we have regions of chromatin which will be more open. And in these more open regions of chromatin, underlying DNA sequences, in particular gene promoters and gene enhancers, which are the elements which control whether a gene is transcriptionally active or repressed, are accessible to the various different transcriptional machinery factors and proteins that actually basically turn genes on. Whereas on the flip side of that, genes that are transcriptionally inactive will tend to reside in more closed regions of chromatin, where these same transcriptional regulatory elements are inaccessible to the transcriptional machinery. And one of the major functional elements that actually controls this differential packaging of the chromatin fiber is the chemical or the covalent modification of the chromatin fiber itself. And this can happen either in the form of direct chemical modification of the DNA itself in the form of methylation, but also the histone proteins within individual nucleosomes are subject to a great many different chemical modifications which affect their function. So in this context, my research program is interested in particular in kind of 4 groups of proteins that are actually functionally involved in regulating and establishing chromatin structure via these mechanisms. And these are denoted here on the right. So on the top, we have a group of proteins which we refer to as chromatin writers. And now these are enzymes that are responsible for depositing these covalent modifications along the chromatin fiber. We then have a second group of proteins which we term chromatin readers. And these are actually proteins that have specialized protein-protein interaction domains, which actually allow them to bind regions of chromatin that have specific covalent modifications or combinations of modifications deposited. There's a second group of enzymes known as chromatin erasers, and these simply oppose the function of the writer enzymes by actually removing these covalent modifications. And then a fourth group called chromatin remodelers. And these proteins or these complexes actually control the positioning and occupancy of nucleosomes within the chromatin structure to basically control the accessibility of underlying DNA sequences. And these proteins, together with some additional factors, kind of functionally converge to control and establish and maintain an appropriate kind of chromatin architecture to hopefully facilitate appropriate gene expression. So why would I be interested in studying these mechanisms and these processes in the context of cancer? And the answer to this question is quite simple. So in the last decade or more now, probably 12 or 14 years of cancer genomic sequencing studies, we've actually learned that the factors involved in controlling chromatin structure and transcriptional biology are some of the most frequently mutated functional classes in cancer. So we know from sequencing adult diseases that about 30% of all cancer driver mutations occur in genes that control either transcriptional biology or chromatin biology, or like I said, might be referred to as epigenetics. And so we now know that about 30% of all cancer driver genes are basically factors involved in these processes. So we understand very clearly now that disrupting these processes is key to cancer development in many contexts. But I'm particularly interested in pediatric diseases. And this is actually even more so the case in pediatric cancers, not just pediatric sarcomas, but other pediatric diseases as well. So as we know, pediatric cancers tend to be hypo-mutated relative to their adult counterparts for various obvious reasons. But despite this overall much lower mutational burden in childhood diseases, we see still a very strong bias towards mutating factors involved in transcriptional and chromatin biology. So in a very real way, in a lot of pediatric cancers, altering these chromatin regulatory and transcriptional regulatory mechanisms are the core disease mechanism. So in essence, what we do in the lab, the focus of what we do is geared around understanding, on the one hand, how these chromatin writers and readers and erasers functionally converge in normal cells to establish a chromatin architecture and a chromatin landscape that's conducive to appropriate gene expression, but importantly, actually, how the mutation of these factors in cancer cells leads to the alteration of chromatin structure and chromatin function to ultimately support a disease-associated or an oncogenic gene expression program. And we do this always with a focus towards trying to translate mechanistic understanding in this regard towards the development and implementation of mechanistically anchored disease therapeutics. And what's exciting about this in particular is that this functional space is inherently druggable. So a lot of the proteins that are involved in transcriptional and chromatin regulation, for example, these writers and erasers and readers, they have enzymatic active sites, they have important protein-protein interaction interfaces that have and are increasingly proven quite accessible to drug design. So small molecules can be designed into these, enzymatic active sites, for example, to inhibit their function. And this table on the right here is actually slightly out of date now. We've taken it from a review that we wrote a few years ago. This is just an example of some of the molecules targeting these kinds of chromatin regulators that were in clinical trials at the time. Some of the molecules in this table have actually since been clinically approved, and various additional molecules have now been added. So there's a real opportunity to translate molecular understanding of these core disease mechanisms towards the development of hopefully clinically efficacious treatments. So I'm going to talk about synovial sarcoma. So I'm sure many of the people in the group know a lot about synovial sarcoma, but just to introduce it, just for anybody who doesn't. So it's actually quite an interesting malignancy in that it occurs at all stages of life. So we're particularly interested in pediatric diseases in my lab, but synovial sarcoma is a disease that occurs both in young and older patients. It accounts for about 10% of all the soft tissue sarcomas that get diagnosed annually. And the long-term survival rate is still actually relatively poor, and with only about 40% of patients surviving beyond 5 years. And what's interesting about synovial sarcoma is that we've known for a really, really long time what actually causes disease development. So way back in the 1980s, these characteristic chromosomal rearrangements were identified in synovial sarcoma patients, and the presence of these translocations is actually still used as a primary diagnostic measure today. And these chromosomal rearrangements involved in chromosome 18 and the X chromosome. About 10 years later, the resulting oncogenic fusion genes and fusion proteins that came from these translocations were identified, and these involve the SS18 gene, which is encoded on chromosome 18, which can be fused to one of three related genes, SSX1, 2, and 4, which are all three encoded on the X chromosome. About 15 years ago now, Mario Copecci's lab demonstrated with a very elegant mouse model that expression of one of these SS18, SSX fusion proteins in the appropriate cellular context in the mouse could cause a 100% penetrant synovial sarcoma-like disease in the mouse, suggesting that the presence of the fusion protein alone is actually sufficient to drive disease development. And consistent with this, cancer genomic studies actually sequencing synovial sarcoma patients have shown that there's relatively little evidence for significantly co-occurring genetic abnormalities in this disease, so primarily driven by the oncogenic fusion protein. And much more recently, functional and biochemical analyses have actually demonstrated that this SS18 SSX fusion protein is actually an aberrant member of an important chromatin remodeling complex known as SWI/SNF. And basically in synovial sarcoma cells, the fusion protein assembles into this complex and actually changes its distribution on chromatin and kicks out some of its existing members. So synovial sarcoma is very much a disease that's caused by aberrant chromatin or altered chromatin regulation. So this kind of spurred my interest in this disease in the first instance, and we started off with a very simple question of, can we identify any chromatin-based functional dependencies that we might be able to pursue towards therapeutic development? So to do this, we actually used custom CRISPR screening profiles, so techniques. So basically we create custom genetic knockout libraries where we can knock out in a very high throughput way many genes in order to systematically identify genes that are functionally essential in any given context. Obviously in this context, this was in synovial sarcoma. And we identified a gene called BRD9 to be functionally essential in synovial sarcoma cells. But in particular, what was interesting was that we found it among a wider panel of pediatric sarcoma subtypes that we examined to be specifically functionally essential in synovial sarcoma cells. I won't go into huge detail here because I think it's the wrong audience, but what we subsequently demonstrated actually using, in this case, proteomic profiling of complexes containing the disease-causing SS18, SSX fusion protein, that actually this protein BRD9 is actually exists within the same oncogenic SWI/SNF chromatin remodeling complexes as the disease-causing fusion protein, initially using proteomics, and we also used ChIP-seq to actually map BRD9 localization along the chromatin fiber, and we showed that BRD9 extensively co-localizes with the fusion protein on various active gene regulatory regions, including enhancers and promoters in synovial sarcoma cells. And this is just kind of shown in this cartoon here. So we identified BRD9 as a component of these oncogenic fusion protein containing complexes bound along the genome with the fusion protein. So how might we actually therapeutically target BRD9? So this is what the BRD9 protein looks like. So this is actually a chromatin reader protein. It has this bromodomain. So bromodomains exist in this class of chromatin reader domains. So this is actually a crystal structure of the BRD9 bromodomain. So what bromodomains are known to do in particular is to bind regions of chromatin that are acetylated. So they're marked with a particular post-translational covalent modification known as acetyl-lysine, and the bromodomain of BRD9, and indeed there are many bromodomains encoded in the human genome. They bind acetyl-lysine peptides via an important asparagine residue which exists within the bromodomain structure. And what's been quite exciting in terms of bromodomain function, in the last 10 years or so, is that this acetyl-lysine binding modality has actually proven quite accessible to drug development, and some people might be aware of molecules targeting the relatively famous at this point BET bromodomain proteins, including BRD4, and clinical investigations involving BET bromodomain inhibitors. So this function has proven quite accessible to drug design. And around the time that we made these discoveries in the lab, actually two separate groups, including Boehringer Ingelheim and GSK, had developed small molecule inhibitors of the BRD9 bromodomain, which bind into this pocket and basically block the ability of the bromodomain to bind this acetyl-lysine substrate. So we were quite excited to get these molecules into the lab to see if they might be efficacious in synovial sarcoma models. So these are just growth response experiments using this molecule BI-7273 for Boehringer Ingelheim and iBRD9 from GSK. And across a panel of synovial sarcoma cell lines, we see a response, a relatively selective response relative to other synovial or other pediatric sarcoma subtypes, although these responses were relatively modest with IC50s in the micromolar range. So we wanted to test whether this relatively modest response was it because the inhibitor wasn't very good, or was it perhaps for other reasons? And one of the ways we went about testing this was we actually used ChIP-seq to map BRD9 localization along the chromatin fiber. So this is some ChIP-seq data. Each one of these peaks actually denotes where the BRD9 bromodomain is bound along chromatin, and then the height of a peak basically denotes greater or lesser binding. So when we treat cells with BI-7273, we can actually reduce the amount of BRD9 that is bound on chromatin, but you can still see here there's quite a lot of the protein bound on chromatin. So with these inhibitors, we weren't able to effectively remove the protein from chromatin. So we wanted to figure out, was this because the bromodomain inhibitors weren't good, or was it because BRD9 is capable of binding chromatin independent of its bromodomain function? So to do that, we actually mutationally inactivated the BRD9 bromodomain. So I mentioned there's this important asparagine residue in BRD9, it's asparagine 216, and when we mutate asparagine 216 to an alanine and express BRD9 in cells, and then again map it using ChIP-seq, we can see even with a mutationally inactivated bromodomain, there's still plenty of BRD9 bound on chromatin. So this led us to this the conclusion that we needed to develop a better way to therapeutically target BRD9. So this led us basically to the development of BRD9 PROTACs, or targeted protein degrader molecules. So for anybody who doesn't know what these molecules are or is less familiar, so these are typically bivalent compounds which on the one end bind a target protein and then on the other end bind elements within the proteasome. And we developed this molecule called dBRD9A, which bound BRD9 and then bound the cereblon protein within this E3 ubiquitin ligase complex. And the bivalent engagement of both targets by one of these molecules can lead to the forced dimerization of your target protein with the E3 ubiquitin ligase complex, subsequent ubiquitination of the target protein, and then subsequent proteasomal mediated degradation of the target. So we can effectively completely remove the protein with a molecule like this. And the molecule we designed, dBRD9A, was a very potent and specific binder of the BRD9 bromodomain relative to other bromodomains. But when we quantify proteins in cells using proteomics, we can find it's also a very, very specific degrader of BRD9, with BRD9 being the only protein that's significantly depleted in cells following 2 hours of treatment with this molecule. So it's very, very potent and very, very specific. And consistent with the fact that eliminating the whole protein would be more therapeutically impactful than just inhibiting the bromodomain, we see in multiple cell lines when we treat cells with dBRD9, we get a much more robust therapeutic response. And then when we map, again, BRD9 using ChIP-seq, we can effectively completely remove it from chromatin compared to when we inhibit its bromodomain. And we established mouse xenograft models of synovial sarcoma and actually showed that treating mice with dBRD9 could effectively arrest tumor progression in mice. And what's really cool about the degrader molecules is we can actually measure relatively easy in vivo pharmacodynamic effect, because we can basically derive protein samples from tumors of treated and untreated mice, and we can actually see here that treatment of mice with dBRD9A reduces BRD9 protein levels in tumors in these mice. So just to finish up, so I mentioned that this is a disease that's caused by aberrant SWI/SNF function, this important chromatin regulator, and there's actually 3 different molecular subclasses of these complexes in cells. And actually this protein BRD9 that we found to be functionally essential in these cells is a defining member of one subclass, this so-called non-canonical subclass of BRD9. So we wanted to understand a little bit more how the BRD9 degrader might be working. So we actually purified these SWI/SNF complexes from cells using an antibody which recognizes this protein SMARC-C1, which basically is a component of all 3 molecular subclasses. And when we purify complexes from cells across a time course of dBRD9 degradation, what we basically see, this is small here, I won't go into detail, but what we basically see is that in addition to losing BRD9 from these protein, from these complexes, we also lose these proteins called glitzer1 and glitzer1-like, which collectively define this particular subclass known as non-canonical BAF. So what we know is that in normal synovial sarcoma cells, we have these 3 molecular subclasses of these complexes. This green subclass, non-canonical BAF, is functionally essential. When we treat cells with this BRD9 degrader, we get rid of BRD9 because we've degraded it, but we effectively dismantle this whole subclass of non-canonical BAF. So just basically kind of demonstrating here again, so this protein is in complexes with this fusion protein, and when we get rid of BRD9, we can displace it from chromatin. And what's been really, really exciting is that in the last few months, really, last year or so, a lot of these protein degrader type drugs have entered the clinic, and actually in the last couple of months in particular, there have actually been 2 independent clinical trials which have begun using BRD9 degraders in synovial sarcoma patients. And as I understand it, the first patients on these trials have actually recently received doses. So hopefully in the next few years, we'll get some positive data reported back from these screens, and we might actually, or from these trials, and we might actually see some clinical impact for patients. So there, I'll just finish up. And again, I'll thank the organizers for the invitation to give the talk. And I'll just acknowledge everybody here who contributed to the work over the few years and funders. And thank you all for your attention.
Thank you very much, Gerard. Impressive review, and in a very topical issue, by the way, because as you mentioned, recently a couple of clinical trials have been activated in with this targeted therapy in synovial sarcoma, which is very, very exciting for the clinicians and those devoted to sarcoma care. So thank you, Gerard, and questions we'll share later on. So I'm sharing my screen for the latest talk. It's my pleasure to share this chondrosarcoma spectrum. Seriously, is there any news on this topic? Yeah, usually chondrosarcoma is a very disappointing subtype within the physicians in charge of sarcoma care, because usually it's considered a chemo-resistant and radio-resistant disease. So it's my pleasure to share some data that can change this concept of resistance. Maybe this is my disclosure, and we will go through these points in the agenda. So some figures in chondrosarcoma is the second most frequent bone sarcoma, with the incidence of 1 or 2 or 3 per million inhabitants a year. There is a high variability among countries. Saudi Arabia or India represents less than 10% of all bone sarcomas, but in Netherlands, for instance, it's more than 45% of all bone sarcomas. Primarily affect adults, 70% after 40 years, the difference of Ewing sarcoma or osteosarcoma. And secondary chondrosarcoma affects a younger population. The incidence is increasing for females in recent times, and in some places in both sexes, as Netherlands, Norway, and England, from an incidence of 2.8 to 8.8 in the latest period of 2005-2013. And conventional chondrosarcoma is more frequent in Caucasian, while mesenchymal is more frequent in African American populations. So data from Istituto Ortopedico Riccioli, they always publish exquisite books, in this case from almost 900 cases of conventional chondrosarcoma. Here is the most frequent bone distribution: femur, iliac bone, followed by humerus and thoracic wall. And by histology, conventional chondrosarcoma comprises 75% of cases, followed by peripheral, dedifferentiated, mesenchymal, juxtacortical, clear cell, etc. So metastatic presentation, according to different histologies, is reflected here in the right side. Up to 20% of dedifferentiated chondrosarcoma are presented are metastatic at presentation time, at diagnosis, and the median of overall survival in different subtypes is also reflected. For dedifferentiated chondrosarcoma, just 11 months. And for conventional chondrosarcoma, the most frequent, the median of overall survival for grade 1 or 2 are 22.5 years, but for grade 3 are just 2 years. So integrating DNA sequencing, transcriptomic and methylome analysis, a molecular classification was proposed mainly based on deep deletions in 14q IDH mutations that entails a wide gene methylation profile and activations of proliferative genes. I don't know if this is very pragmatic, this classification. In the end, the authors built a transcriptomic signature selecting just 2 different prognosis population. And maybe this would be more effective if we are focusing on just one specific chondrosarcoma, for instance, grade 3 conventional chondrosarcoma, just seeing the differences in behavior or maybe in prediction of some therapeutic approaches, rather than to present all the subtypes inside, and it's more difficult to understand this kind of analysis. But in any case, it seems interesting because it reflects some genetic alterations that are important in this disease. So classical chondrosarcoma is considered, as I mentioned before, a chemo-resistant tumor, but some activity could be demonstrated in any case. In the context of advanced chondrosarcoma, this is a French series of 180 patients treated with chemotherapy in advanced disease, in combination 1998 and in monotherapy 82. And as you can see here, the overall response rate according to subtype, 31% in the case of mesenchymal chondrosarcoma, 20% in the case of dedifferentiated chondrosarcoma, just 11% in the case of conventional chondrosarcoma, and just 0% in this low-grade subtype as clear cell chondrosarcoma. Interestingly, in the multivariate analysis, the administration of chemotherapy was an independent significant prognostic factor, and the combination seems to be more active in this advanced disease, as you can see in the Kaplan-Meier curves. It's true there is a trend to use osteosarcoma regimes for dedifferentiated chondrosarcoma and use human sarcoma regimes for mesenchymal chondrosarcoma. So, but also in perioperative administration, in this case, in localized mesenchymal chondrosarcoma, chemotherapy can be indicated, and this is the case of this retrospective series where chemotherapy administration was significantly better in terms of univariate and multivariate analysis. So in this case, it seems to be very clear the advantage of giving chemotherapy in a perioperative setting, in mesenchymal, in this case, chondrosarcoma. So knowing that chondrosarcoma exhibits an overexpression of MDR genes as PGP or MRP1, we explore the combination of nilotinib, which is a MRP1 inhibitor, very powerful, by the way, as a coadjuvant of doxorubicin in a phase 1 trial enrolling patients with L-sarcoma and chondrosarcoma. And as you can see here, there were different median of progression-free survival after receiving this combination. Very, very different. Maybe it's difficult to withdraw any robust conclusion, but maybe in some cases this seems to be active. For instance, a grade 3 with 22 months of progression-free survival, or 14 months in two cases. So some examples of some activity. We had a robust preclinical experiments demonstrating synergistic action between doxorubicin plus nivolumab and nilotinib. And nilotinib was administered just 6 days as a coadjuvant of doxorubicin. This scheme was safe, and we have analyzed also in mouse the impact in cardiac tissue, and there was no greater damage in the cardiac tissue with the combination. So this could be considered safe. So many signaling pathways have been suggested as potential drivers in chondrosarcoma: IDH mutations, Hedgehog pathway, SRC, PI3K, mTOR, histone deacetylase inhibitors, and angiogenesis as well, and immunomodulation, immunotherapy. And we will not go through this, through all of these, but in some of them. Surprisingly, one of the most promising therapeutic avenue in chondrosarcoma is not among these these pathways, as we will share later. Anti-angiogenics have been proposed for more than 10 years ago in chondrosarcoma. This is one of the earliest case report. Curiously, this case is an advanced clear cell chondrosarcoma, very unusual for this low-grade chondrosarcoma. And in this case, a complete symptomatic pain relief was obtained along with a partial response by PET scan with sunitinib, which is to the best of my knowledge, the first report of anti-angiogenic in chondrosarcoma. But there are two different phase 2 clinical trials. This is with pazopanib, and authors reported a median PFS of near 8 months and a median of overall survival of 17.6 months. Only one partial response was objective, but 35% there were some shrinkage with pazopanib. The fact that different grades were included from grade 1 to grade 3 raised the question if this survival outcome is positive enough, because it's difficult when different prognostic population is enrolled. And in this study, a prospective study comparing it's a randomized, not comparative trial with regorafenib versus placebo. The PFS was better for regorafenib, 20 versus 8 weeks, but the overall survival was not superior for regorafenib. Nevertheless, considering the patients with crossover, it seems clear that the time of progression-free was superior after crossover, favoring regorafenib, as you can see here in the swim graph. So this is the anti-angiogenics summary in chondrosarcoma, just 3 experiences and with some little, let's say, activity. So moving on, the cell cycle regulators, we only have some preclinical rationale, and to the best of my knowledge, no clinical trial have yet been performed in chondrosarcoma with these compounds, but this preclinical rationale seems robust enough for considering this option as well. And this could be interesting, maybe in combination, but obviously we need to know as monotherapy activity. So with the finding of more than 50% of conventional and dedifferentiated chondrosarcoma harboring IDH mutations 13 years ago, I think this is, I think, a big discovery. And finally, we have some candidates for exploring this targeted therapy. This is globally, the mutation of IDH entails a globally gain of function mutation, despite the mutation leads a loss of enzymatic oxidative decarboxylation of isocitrate. But in total, there is a gain of function mutation with a higher reduction of the substrate. So the kind of mutations are a missense affecting arginine residues, and there are some specificity in some drugs, in azidanib with IDH2 mutations, and other compounds with IDH1 mutations. So in general, chondrosarcoma patients bearing IDH mutations have worse prognosis. And so this is the experience with ivosidenib, a selective IDH1 mutant, was explored in a phase 1 trial led by William Tapp, one of our speakers, in advanced IDH1 mutant chondrosarcoma patients. No DLT was observed, but maximal plasmatic inhibition of 2-hydroxyglutarate was 500 milligrams. 52% of stable disease was reported, and a median of PFS of 5.6 months. So the treatment seems to be more effective in conventional chondrosarcoma than in dedifferentiated chondrosarcoma, so that the focus is in conventional, it seems the control is good enough for many patients, and the safety profile seems favorable and manageable as well. So this is some hope in this regards. And moving on to the next candidate, DR5 agonist. Its history started as far as 1 decade ago, when a 65-year-old patient was enrolled in a phase 1 trial with dulandermine, a bivalent DR5 agonist. It's true that this chondrosarcoma is not a typical conventional chondrosarcoma. Indeed, was derived from malignant transformation from synovial chondromatosis. But the striking fact was this patient experienced a partial response, and the tumor was under control for more than 60 months. And this is a remarkable finding. 8 years later, in CITOS 2020 meeting, a phase 1 trial with Imbrix 109 was presented. This is a tetravalent DR5 agonist with one intravenous administration every 21 days. And this compound clearly had a higher preclinical activity than bivalent or trivalent compound. And this is an example of a partial response. There were 2 partial responses in this phase 1 trial, as you can see here in the bottom place. And this is another example of a skull chondrosarcoma with a partial response with this drug. And interestingly, apart from these 2 partial responses, 75% of stable disease was reported, for a total of 92% of disease control rate. And in 67%, there was some shrinkage in this small series. And in a more recent updated, presented in CITOS 2021 with 18 patients, the total disease control rate was almost 90%, and in 61 had some decrease in size, with a shrinkage of at least 10% was seen in 33 patients with a median PFS of 7.4. In other words, this seems to be very appealing, and now the clinical investigations is moving to later phases. So this could be very, very interesting. So the safety profile seems good, with just 5% of grade 3 or greater in liver toxicity, which is maybe the most important, but in general, the toxicity profile was very good. So other options on the table, a Hotchkiss inhibitor failed to demonstrate benefit in a randomized phase 2 trial in chondrosarcoma. SRC inhibitor reported some overall response rate, but measured by Choi criteria, with a median of progression-free survival of 5.5 months. Sirolimus and cyclophosphamide also demonstrate some activity with 1 partial response in a retrospective series. Imatinib failed to show signal of activity in this specific population. Immunomodulation is currently ongoing in some trials as immunosarc2, and we have seen some interesting responses in immunosarc1, which is exploring the combination of sunitinib plus nivolumab in several selected sarcomas. And this is one of the cohorts of immunosarc2, specifically with dedifferentiated chondrosarcoma. And you can see here one relevant partial response with this patient had an impressive improvement in symptoms as well. And this is another example of a response with this combination in the context of dedifferentiated liposarcoma within the clinical trial. So my remarks are maybe control the heterogeneity is crucial to talk the same language. Maybe we have to to make some adequate selection for clinical trials, because otherwise the figures are jumping and it's difficult to ascertain if one scheme is active enough or not. Anti-angiogenics and IDH inhibitors showed some activity in conventional chondrosarcoma. It's a promising activity. Immunomodulation also deserved to be explored in the context, as I mentioned, of dedifferentiated chondrosarcoma. DR5 agonists are among the most promising agents in conventional chondrosarcoma. IDH inhibitors and DR5 agonists have a low toxicity profile, maybe are good candidates for combinations. Phase 3 trial is ongoing for Imbrix 109 versus placebo. This is the DR5 agonist, and other potentially active compounds with some preclinical rationale are CDK4 inhibitors, mTOR, and Wnt inhibitors. So thank you very much for your attention, and we will go through the questions now. I will start with William Tapp. You explained in a brilliant way, as usual, some potential predicted biomarker of success for CDK4 inhibition with senescence as the goal. But what about this third of patients with worse outcome? Do you have information about what is the reason of this lack of activity in this third of population with CDK4? Is just because RB no proficient, or what is the main reason of this lack of activity in this third of population?
It's interesting. I mean, I think looking at it from a senescence standpoint, we think a lot of the resistance is going to be mediated by RAS signaling in a lot of the cells. I think there's a rare population that can have ATRX mutations in the C-terminal domain. All of the patients that went on clinical trial were RB positive, which we know is really high. So we don't think that is an area of innate resistance. We think it's going to be more in the ability of the cells undergoing quiescence to senescence. Now, we are just looking at it from a geroconversion pathway, so there's probably other mechanisms of action and resistance as well, which I think, you know, will also be really interesting to understand that. And we're currently looking into other resistant, you know, some of the data from breast cancer about loss of RB or overexpression of some of the cyclin-dependent kinases, cyclin E's, things like that. So I think what's important, though, is getting these larger data sets from SARC41, you know, to interrogate and trying to get some of those samples, and looking at larger populations becomes really important. I also think looking at some of the predictive biomarkers in the science with the different drugs becomes important as well, because they are slightly different in their mechanisms of action.
Okay, thank you. What is your thought about the inhibition in well-differentiated liposarcoma? Because we have some patients that are not candidates for surgery, and the tumor is growing. It's true in an indolent way, but it's growing, and sometimes this entail symptoms or difficulties. So what is your experience regarding the MDM2 inhibitors, for instance, in the context of well-differentiated liposarcoma? It does make sense to test this population?
I think so. I mean, I don't think we're going to see high response rates. I think anecdotally, we've all had patients with progressing well-differentiated liposarcoma, which becomes very difficult. You know, these large mediastinal tumors and even retroperitoneal tumors. We've seen anecdotal responses from drugs like selinexor, MDM2 inhibitors, CDK4/6 inhibitors. Nice data from the Italian sarcoma group looking at trabectedin, right? So potentially some variants, and even some of the immunotherapies, but I don't think consistency with any of these inhibitors is going to be the hallmark. Again, I do think MDM2 inhibitors are probably the most exciting in that regard, just because we see this 12q amplicon early on in well-differentiated tumors, and it does, the copy number gains increases over time. So looking into MDM2 inhibitors, I do think there was a well-differentiated cohort on one of the MDM2 trials, which will be important, but very frustrating tumors when we all see them. And I do think we need some consensus of therapy for them.
Thank you. So I don't know, Bruno, is there any question here?
There is a question for Bill Tapp. The question is, was there any stratification for grade in the CDK4 trial, G1, 2, or 3?
Yeah, so it's a great question. Early on, we kind of took all comers, in the sense of needing a dedifferentiated component, but there were some well-differentiated and dedifferentiated tumors. So, it was nice to see responses in both. Early on, all patients needed to be RB positive by IHC, and all patients needed to have progressive disease going on to the clinical trials. Later on with the clinical trials, we allowed we didn't screen for RB because we know it's about 95, 96% penetrance. We allowed first-line therapy, just dedifferentiated, and then again, making sure patients had progressive disease going on to the trials, because I think, as we all know, these tumors can also behave indolently sometimes. So we worry about misinterpreting results in data as well.
Bruno, I have a question.
Yes,
I have a question for Bill. Hi, Bill. I'm Axel. You cannot see me because my webcam, I don't know what's happening.
Good to hear your voice, though.
In your experience, have you any experience of surgical removal of liposarcoma after an anti-MDM2 or anti-CDK4 inhibitor maybe during the trial, or and if yes, do you see a difference at biological level, decrease of amplification of CDK4 and MDM2? As mentioned before, I'm really disappointed, especially in retroperitoneal liposarcoma. MDM2 and CDK4 is maybe the causal event of liposarcoma, but with these drugs, something happened in some patient, but it's not a revolution. Do you think it is a PK problem? A drug cannot going inside the tumor. So if we can operate some patient after this approach, it could be helpful to understand the mechanism of these drugs.
Yeah, it's a great question. I mean, we're gathering a cohort of patients who are operated on as they progressed with longer term exposure to CDK4/6 inhibitors, and hopefully begin to generate some of that genomic data looking for mechanisms of resistance. Anecdotally, we have seen some cyclin E upregulation, not so much downregulation of CDK4. So, but I think we do need larger number of samples. It's hard to say why we're not seeing these types of great responses across the board. And I personally think that it's because of the heterogeneity of the disease. Often these tumors are 30 centimeters, and so you're having subpopulations of cells in there, and we finally have been able to definitively identify some senescent cells in some of these tumor samples, which has been elusive before. And looking at, by doing landscape analyses of the tumors, you're seeing different populations that can undergo senescence, some populations that can only quiesce, and then also seeing the different immune environments that you see within a tumor. So I think it's the complexity of the disease that's driving the heterogeneity of the results. I also think when we use the drug, we have to be thoughtful in what we're looking for. These are not drugs that are going to have immediate effects, and definitely not regression in size, but it's really the slower, over time, allowing for stability, right? And how we achieve that becomes really important. And then also hoping we can find these combinations. But I agree with you, these are tumors where we should get a lot of data after exposure to drug so we can understand what's going on. The other thing I'll say is that, you know, there's probably emerging data in the literature that long-term senescence in a lot of tumor samples is not necessarily a good thing. You know, could that also trigger a pro-tumorigenic environment? So it calls into the question of whether or not down the line we would have to combine these types of drugs with a senolytic or something else to remove the senescent cell. It's a great question.
Hey, thanks.
Thank you. So we can move to questions for Gerard, Brian. I don't know, Gerard, do you consider there is some robust predictive biomarker for the inhibition of BRD9, or is just BRD9 expression, or what is your suggestion for a predictive biomarker for effectiveness?
Yeah, no, it's a good question, and I guess time on trial will hopefully help. But I think one of the advantages we have with these kinds of fusion gene driven malignancies, whether they be sarcomas or leukemias or other kinds of diseases, is that quite frequently the fusion proteins are the one driving element of disease biology, and that is true in synovial sarcoma. So in essence, in that kind of scenario, you know, if we could therapeutically target either with the drug or something, the fusion protein directly, we could have a very, very impactful therapeutic. But that hasn't, in some cases, like, you know, PML-RAR in some certain blood malignancies, that is actually possible. But in, you know, synovial sarcoma, currently it's not possible. But in BRD9, what we basically have is a direct cofactor that actually functionally supports the oncogenic role of the fusion protein that causes the disease. So, like, I'm quite hopeful that the presence of, you know, the fusion protein, which in this context defines the disease, is the biomarker that is predicting, hopefully, response to BRD9 targeting. So, you know, that's probably overly ambitious, I'm sure, as is the case with any drug trial. There'll be a mixture of responses, but I would hope, because in BRD9 we've found basically, you know, one of the partners that the fusion protein actually uses to drive disease, that we could potentially have a very significant impact on patients, but we'll see with time.
Thank you. Emanuela is raised the hand, so I don't know if she has a microphone for the question. Emanuela? Now you are muted now.
I think I unmuted her. We should see her or hear her at least. She writes, I cannot unmute me. Eugen, can we do that?
Okay,
No.
okay, now it's working. Okay.
Oh, now we hear you. Yes, great.
Thanks everybody for the great update and summary of this molecular new target. I have a curiosity for Brian. Do you know which is the limitation from bromodomain inhibitors in other solid tumors so far? I mean, I've been knowing this drug for melanoma or other tumors. So if there are some maybe combination that might be worth trying, and also if there are any other, since being an epigenetic target, other translocation related sarcomas that are already shown sensitive to bromodomain inhibitors. Thank you for your talk.
Yeah, no problem. Yeah, so these are good questions. So I mentioned during the talk that, you know, bromodomains have emerged in the last decade or so as promising therapeutic targets, and that's mainly based around discoveries of functional requirements for a family of bet bromodomain proteins called, or a family of bromodomain containing proteins called bet proteins, which are most famously BRD3 and BRD4. So there are clinical trials in, utilizing bromodomain inhibitors targeting those proteins. Effectiveness, I suppose, is as is the case in a lot of trials, mixed. One of the difficulties with bet bromodomain proteins as therapeutic targets, as I see it, is that we know from functional studies in cell models that bet bromodomain proteins are actually essential for transcription, and the potential toxicity of inhibiting these proteins, I think, is potentially quite negative, because what you're effectively doing is shutting down transcription when you inhibit bet bromodomain proteins. So I personally think bet bromodomain inhibitors, which are the kind of, say, the class leader in terms of bromodomain targeting drugs, I'm not sure how effective they're going to be in patients, because I think the potential for toxicity is probably too high, because you're inhibiting a very, very essential process that every cell cares about. But what was interesting in the context of BRD9, so we are not inhibiting per se BRD9 bromodomain function. Well, we are, but we're inhibiting more, because what we found was with the inhibitors of the bromodomain, the synovial sarcoma cells don't really care so much about if we discretely inhibit the BRD9 bromodomain, but they really care if we eliminate the protein. So that's why we moved on from using inhibitors to using degraders. And the reason we know this now, I didn't really talk about this in great detail, but the reason we know this is that other elements within the protein are functionally essential, and they actually support formation of these oncogenic complexes. So I think the therapeutic effect of targeting BRD9 is not so much coming from targeting its bromodomain, it's coming from actually targeting the protein as a whole. But then to your second question, in terms of other opportunities for bromodomain inhibitors, or just other epigenetic drugs in fusion gene driven diseases, there are, the lab that I did my postdoc in, Scott Armstrong, so Scott's lab study pediatric fusion gene driven leukemias, and there are drugs inhibiting DOT1L, which have shown some efficacy there. There's new drugs coming out targeting a protein called menin, which is an epigenetic regulator that has shown some significance there. Part of what we do in the lab, we use these kinds of CRISPR screening platforms to systematically identify epigenetic dependencies in other malignancies, and fusion gene driven malignancies in particular. So we have some work in the lab at the moment that we hope we'll publish in the next year or two, with new therapeutic opportunities in synovial sarcoma, but others as well. And I think hopefully the work that we're doing will ultimately maybe feed into some of the work that we've done with targeting BRD9 to create, sensibly designed combination therapies based on targeting multiple epigenetic mechanisms in these diseases. So hopefully there will be significant impacts with some of the findings that we have in the lab at the moment.
Thank you.
Thank you, Gerard. Other questions for Gerard Brien?
Javier,
Or
can I
any
ask
other?
a quick question?
Yeah.
Gerard, that was an amazing talk, and I appreciate it. I was struck by the selectivity of the compound. It seemed like it really, I think it targeted the non-canonical BAF complex. Is that where BRD9 is? But I was wondering if any of the other BAF complexes, polycomb, could rescue, the translocation or the effect of the translocation in any way. I didn't know if SS18 was important in any of those, or if there's some thought about how those complexes are related in that regard.
Yeah, so that's in essence, that's a core focus of the lab now, is actually pulling apart these different complexes, because the reality is we know very little about how the discrete complexes function relative and differently from each other. And I think understanding that is key to understanding quite a lot in cancer biology, because we know SWI/SNF complexes are very, very commonly mutated across the breadth of human cancers. And one of the things that's quite clear from the cancer genomic studies is that depending on the malignancy that you look at, different versions of these complexes are preferentially mutated. So most of the mutations that happen to SWI/SNF members are, they're at least thought to be loss of function mutations. But, so synovial sarcoma is a little bit of an outlier in that regard because it's a gain of function fusion. But in essence, we don't know a great deal about how the individual complexes work. And I think understanding how they do work will have significant implications, because we know, for example, in kidney cancer, one version of the complex is very preferentially disrupted, whereas in ovarian cancer, a different version of the complex is preferentially disrupted. So I think there's a lot of important work happening, not just in my lab, but globally, in terms of actually pulling these complexes apart. And you mentioned polycomb. Obviously, anybody who's familiar with SWI/SNF or polycomb understands that there's a very long established functional antagonism between the polycomb and SWI/SNF systems, and there are drugs targeting polycomb complexes. So this tazemetostat drug from Epizyme, which is now clinically approved to treat EZH2 mutant lymphomas, but also one of the other contexts that drug is approved to be used in is SMARCB1 mutant malignant rhabdoid tumors and epithelioid sarcomas. And those are diseases that have loss of function SWI/SNF mutations. So there's definitely scope for targeting EZH2 or targeting polycomb function in some of these diseases that have reduced SWI/SNF function, because we know from going back to studies in flies in the 70s that these systems work against each other. So if you tip the balance in one direction, you potentially in patients create a therapeutic vulnerability on the other side of that system. So yeah, I think there will be significant opportunities to kind of hit one side of the system when the other is out of balance and so forth.
Yeah, it's great. Thank you. Wonderful talk.
Thank you. So I think we are approaching to the end, and I think we have very lucky for these professors as speakers initiating another season of webinars from the Swiss Academy. So it has been awesome, and this is in the end makes more hope in the patients as well, because liposarcoma, the differentiated liposarcoma, synovial sarcoma, and chondrosarcoma has now expectations with targeted therapy that can be change or transform the outcome, the clinical outcome in the upcoming times. So investigations are under trial now, but very helpful time for these diseases. And this has been my pleasure, Bruno, introducing these great investigators. And so thank you very much for them. And it has been my big pleasure.
Also from my side, I only can thank you. Great 3 presentations, and I think it opens up the avenues how to proceed and how we can further help to our patients. With this, I'm thrilled that we can conclude, and I would like to thank our sponsors again, and also announce the next webinar, October 20th, about lymphatic surgery in sarcoma patients.